Well, thank you very much for having me here. Certainly, it's been exciting times lately with this project. So I'm quite happy to provide you with a presentation of, yes, what we call putting the brakes on brakes, and a little bit of a fun thing about, thank you, a little bit of a word thing. But I think it's so important to realize that in order to prevent fractures, we have to do three things. We have to prevent falls, we have to manage osteoporosis properly, and for a patient who has sustained a fall, we have to properly manage those patients and investigate them for osteoporosis. So what I'm going to show you today is the EMR application for those three pillars of a bone health program. So it all started 4 years ago when I did a practice reflection exercise. And we were tasked to take 40 of our patients that were either identified as being osteoporotic or were on osteoporosis medication. We were to do a chart review and assess their bone density, assess if we properly treated them, if they had follow-ups, if they were still on their medication. And what I realized from that exercise is that I was really poor at osteoporosis. I did not know my 2010 Osteoporosis Canada guidelines. I was treating a whole bunch of people for what I thought they had osteoporosis because their BMD was minus 1 point something, and I had them on medication, and I had a whole bunch of my fracture patient that had fragility fractures that I hadn't put on osteoporosis medication. So I was also part of that care gap of post-fracture care. So that's where it comes that tell me and I forget, teach me and I remember, and involve me and I learn. And I've learned so much through these years, and I do hope that I'll be able to transfer that knowledge and drive that same passion in some of you to be able to help our patient for bone health. I was very fortunate to have a son who is an IT expert, and he works in a family health team. When I started on the EMR in 2009, my first prescription was QVAR. I had to look on the keyboard to find the letter Q. And then people keep on telling me when I say that story, but don't you know that the letter Q is the first letter? Who would have thought that the first letter on the keyboard would be almost the last letter of the alphabet? So that's how I started off, and it all went from there. So what we're going to do today is we're going to provide you an overview of this bone health programs with its three pillars: fall prevention, osteoporosis management, and post-fracture care. We're going to show you with some videos the EMR applications that we've developed, some of them. If I was to show you all of them, we would be here probably for 2 or 3 hours. And we're going to focus on the one that we participated in from the Champlain Lynn that did a pilot project on the EMR tool for fall prevention. So I don't know if you're like me, but when I first started on the EMR, this is what I felt like. It was driving me crazy. I could not figure out where the keys were, what to do, how to start, even start the computer. Had to constantly ask my staff to come in and help me out. But then we realize it's so easy. It's like playing piano. You learn it and you don't forget it. So the demonstrations I'm going to do on those videos are fake patients. They're not real patients. So Mrs. Porosis by last name, osteo first name, does not exist in the province of Ontario. She does not have a true chart. So hence there is no PHI, no personal health information that's demonstrated on the videos. And as a disclaimer, starting this and doing this on my own, I tried as best as possible to follow the guidelines. But like anything, any guidelines, it should not supersede the decision-making process of the clinician. So every patient is an individual, and sometimes a guideline does not quite fit each one of those patients. So this is today's states of guidelines and algorithms. We're inundated with them. So which one to choose? well, I opted because of that little practice review to try to do it with the 2010 clinical guidelines for Osteoporosis Canada. And why? Why should we choose that one? Well, I'm here today probably talking to converted, but in any case, let's review some of the stats. Osteoporosis fractures are more common than MI, strokes, and breast cancer combined. And yet we put so much focus on cardiovascular disease. 1 in every 3 women and 1 in every 5 men will sustain an osteoporosis-related fracture in their lifetime. And osteoporosis and its complication cost $2.1 billion to the Canadian system in 2010. These are staggering numbers. There's 20,000 to 30,000 hip fractures in Canada every year. And the cost of a fracture is between $20,000 and $40,000 if the patient becomes institutionalized. And the unfortunate thing is that care gap. Less than 20% of patients who have sustained a fragility fracture will be evaluated for osteoporosis or receive appropriate treatment. Again, staggering numbers. What about falls? 1 in 3 of patients over age 65 fall once a year, and a quarter of those will result in injuries, and more than 90% of fractures in elderlies are due to falls. And again, the cost is astronomical. What is it that makes us having such a hard time taking care of that population? We're busy, we're running, we're seeing patients all the time. We're now seeing patients probably 5, 6 per hour, trying to incorporate fall risk assessment, multifactorial assessment, rechecking if your bone density is due or not, has become unmanageable in a paper-based system. The time involved, as I say, it takes too much time. And that's why we went on to try this EMR template. Also, from a patient perspective, adherence to therapy. We do know a great majority of patients, and unfortunately I don't have the stats in my head right now, at 1 year post-initiation of the osteoporosis medication is not on their medication. Cost of therapy can be prohibitive, and the monitoring of therapy. So our physicians are ordering a bone density, 2, 3 years later, they reorder a bone density. The time involved to recheck, to go back to your previous one, to assess if you have had a loss of greater than 3%, it takes too much time. Again, a time involvement. So how can we leverage our EMR in order to reduce that care gap with the 3 pillars? So I don't know if some of you were at the regional geriatric AGM on Friday. So we had a poster, and this poster actually described the 3 pillars of the bone health program. The Champlain here, whoop the dice, sorry, going too fast here. So we see here the fall prevention, the Osteoporosis Canada guidelines, so bone assessment for osteoporosis and management, and then the post-fracture care. And what we did with the Champlain-Lynn trial was that we established it as a, let's try it and see. And the response was overwhelming. The physicians, 97%, I'll show it on another slide, but 97% of the physicians said they were going to continue doing the fall screening through the EMR because it was such an easy thing to do. And you see here, this is the paper-based system. Very hard to navigate through that. So we're going to go through each one of these pillars and show you the EMR applications. So the Champlain-Lynn fall prevention, so what we did is we, as a goal, we wanted to screen for falls once a year in patients over 65 years of age plus. And for those that were identified as being at risk, we were conducting a comprehensive fall risk assessment, and then through that assessment, we would modify the risk factors in order to prevent falls. And those were the screening the EMR tools. We had Reminder for screening, a fall algorithm tool plate, a custom form, and EA means an encounter assistant. And what that is an EMR tool that helps you just click the answer and it populates the next question and the next question to follow the algorithm. And then we had an automated referral to the fall prevention clinic. And again, so the 97% reported that they were likely to continue the fall screening using the EMR, and 80% reported that they were going to do the fall risk assessment. And that multifactorial risk assessment is fairly extensive. So 80% said they were going to do it, and we were very pleased and very surprised by that number. For the osteoporosis guideline, we have screening for osteoporosis, assessment of the bone density, evaluate the patient, whether the patient should be on pharmacotherapy, counsel for lifestyle, and evaluate for adherence to therapy. And again, these are the tools that we'll describe. And then the post-fracture care. And those modules actually follow the Osteoporosis Foundation 13 Best Standards. And I won't go through all of these. It goes through 12 of them. The 13th one is the provincial database, which we don't have set up. And again, these are the tools I'll describe to you. So let's go through the Champlain and Fall Prevention Initiative, and this was in collaboration with Christine Gagné-Roger, Kristen Bede-Mead, which I see here. Is Christine Gagné-Roger here? No? Christine, do you want to show your hand? Oh, you're Diane. Where's Christine?
She went back to London.
She went back to London. Sorry about that. And Diane also has been part of this. And then we had Pascal, and we had also Amir Afkam. And for some reason, Amir's name is not there, but I apologize to Amir if he's online. Actually, Amir has been instrumental in getting us going, keeping us motivated, and reviewing the stuff that we had done. So what we were doing, screening for falls in patients over age 65 once a year, conduct a comprehensive fall risk assessment to identify the contributing causes and risk factors in those who have fallen, and then implement a strategy to target the modifiable risk factors, because we know that many of the risks that are identified are reversible, and hence falls are often predictable and preventable. So this process was that the Champlain developed a strategic regional approach based on the 2011 provincial guidelines. A review of the literature was done, and an algorithm that was expanded from the simple state-independent checklist was produced. And that algorithm and the multifactorial risk assessment was tested in the community on a paper-based system. And one of the findings that came out of that pilot was that it was a great thing to do, but it needed to have an EMR application. In Ottawa, we have what we call the PSS user group. We're a community of practice that gets together on a biannual to quarterly time period, and we share in our EMR innovation to optimize our EMR. The opportunity then appeared to be evident that we could actually be the group that takes this on and tries to do that pilot, and we did. So it was a try-it-out approach, and the group that tested it was very overwhelmingly positive about the outcome of it. So this is our stay-independent checklist on a paper-based system. And this is the algorithm, the Champlain Fall Prevention algorithm, where you start by screening. You answer yes or no. And depending on your answer, if it's yes or no, you walk yourself through the algorithm. If you're identified as being at risk, you do the multifactorial risk assessment. And if you're not at risk, well, counseling is also important. Exercise, vitamin D, other programs that people can go to, and then decide whether appropriate referral to the fall prevention clinics in the community. And this is the multifactorial base assessment on a paper-based system. And you see in red here the three Ps: postural hypotension, pills, medication, pain, gait, balance, and mobility problems. When we did the trial, one of the things that came out from the physicians was that this is very long to do. If I was to do this in my own practice, it would take probably a good half hour to run through this with the patient, if not longer. So the question was put, give us the 3 main things that we can do to help our patients, and this is what we were produced with. So let's go to some of the videos.
This person is over 65 years of age and has not had a fall assessment in the last year, as seen here by the toolbar. If the patient had a fall assessment done, the toolbar would not be visible and will reappear after 365 days. Let's go through our algorithm. So we go through and answer questions. And I want you here to notice the Stay Independent checklist score will increase accordingly. So the first 2 questions are worth 2 points, while the next questions are worth 1 point each. So we see here that our score is 6 above 4. So did we answer yes to the question above? Yes, we did. And we evaluate the gait, whether it's normal or abnormal, and whether the person is using a cane or not. We document the fall. And then we establish if the recurrence of fall is likely. If not, has there been only 1 fall or several near falls? If there was only 1 fall, then the risk of falling is low. If there are several falls, then it is a higher risk of recurrent fall, and we can either perform the custom form as seen here or the encounter assistant that replicates the custom form. We can also send an internal message to our nurse practitioner to perform the multifactorial risk assessment. We can also send a message to our staff to book a follow-up appointment to perform the multifactorial risk assessment. Let's complete this, and you will see the automated message to the staff to book an appointment, or to our nurse practitioner to evaluate with the multifactorial risk assessment, as seen below here. You will see here in red 3 important items to evaluate our patient that are modifiable risk factor and could prevent further falls: postural hypotension, polypharmacy, pain, gait, mobility.
So you may have noticed on the bottom left. Being on the opposite side is hard to know. So bottom left, down here, there was useful links so that the physician could just click on the link. If there was a pamphlet to give. It also would click on the referral to the fall prevention clinic. Information about the community exercise programs. So all of those links were there. You will notice there's a little bit of some errors there. These were produced several years ago, as I said. If you do notice a little bit of error in the way that it was written up in terms of the different programs, I apologize. And we went over this already. So what about osteoporosis in itself in the 2010 Canada guidelines? So this is the guidelines. So when they came around in 2010, a lot of us, and I'm speaking for myself and what I know about my other colleagues, we put that and we put it on the shelf. It looked too complex to try to figure this out. But as we worked through it, it actually ends up being fairly simple. So in the Osteoporosis Canada guidelines, of course, we want to be able to screen our patients appropriately. Gone are the times where a patient now is coming in to see me and saying, I just started menopause 6 months ago. My neighbor had a bone density done, and I would like to have one done too. Doing the screening tool is very useful, and when you do it in front of the patient, it actually is even more powerful to reassure your patient that at 51 years of age, you don't have any risk factors. We shouldn't be spending precious dollars on a test which we will likely not have activity to do. And then is when to remember to repeat the bone density once you had a bone density done. Are you flipping back in your paper chart to look when your last bone density? Was it low risk? Was it moderate risk? All of the EMR tools helps you to do this without even thinking about it. When you just open up your chart, it populates the reminder box. So we'll show you what the reminders are about.
So let's have a look at reminders. We all know that according to the 2010 Osteoporosis Canada guidelines, that all men and women after age 65 should have a bone density. Our patient here is 58 years of age. Let's put her at an age over 65. You will see here that the reminder box will be populated with the recommendation of ordering a bone density. Let's have our patient have a bone density, and let's put the risk as being a low risk result. We will see here that the reminder of doing the bone density has disappeared. Let's put this bone density at being more than 5 years ago. You will see that the reminder will repopulate with doing a bone density. As the result is a low risk bone density result, recommendation is to repeat every 5 years. If this was a moderate risk bone density and the patient had it done more than 3 years ago, the reminder would still populate to order a bone density. If she had the bone density done just last year, the reminder would disappear. Now let's say our patient was less than 65. Let's put her at 58. We will see that the reminders disappear. Let's say she had suffered a fragility wrist fracture. We will see that this will populate to order a bone mineral density. This will only populate if the patient is over age 50. Let's remove this, and we should see the reminder disappear. Let's say her mother had a hip fracture. Again, we will see the reminder populating with doing the bone mineral density.
So the only activity really a physician needs to do is populate fragility fracture in the history of present illness and the family history of either osteoporosis or a hip fracture. I've trained my scanners to actually do the activity of populating low risk, moderate risk, or high risk on the bone density, so I don't even need to think about that. Oops, let's go next one. Okay, so screening. So we screen everybody, men and women, after age 65. For age 50 to 64, certain criteria, and under age 50, other types of criteria. So let's have a look at how we do it through our EMR.
Let's have a look at our screening tools. Let's do F2, BMD. Let's do the screening for age 50 to 65, and we go through the questions of the screening questionnaire. We also evaluate for the risk for falls, and if we have answered yes to any of the questions above, the guideline recommends that we do a bone mineral density testing. We choose the requisition of our choice that we add to the notes, and we finish. This will then populate the chart with your answers that you can just simply copy paste into the requisition that will indicate to the radiologist the reason for the screening before age 65.
This has been powerful for two things. to convince my patients they don't need a bone density, and to convince my patients they need a bone density. So by walking through with the patient, looking at the screen, going through the questions, and also giving them that opportunity to ask questions about why are you asking that question? Why in particular would that increase my risk? Has increased the patient care experience. So let's go back to our guidelines. And so we did our bone density, and this is the easy part on the guidelines. It's low risk, no need for pharmacotherapy, do some counseling. High risk needs pharmacotherapy and counseling. And then it's the moderate risk people. Who should be on medication and who should not? Well, then we go through the different criterias to establish whether there's no need for pharmacotherapy, and just to repeat the bone density in 1 to 3 years, or there's good evidence for pharmacotherapy. And then, of course, we do, first of all, our history, our physical examination, and then we have investigations. So we have 2 tools here to walk through this part of the Osteoporosis Canada guideline, the custom form and the encounter assistant. So whenever you see the terms EA, that means encounter assistant.
So let's have a look at a custom form, F2 BMD custom form. We see here that the information is drawn from the chart into this table, and to the right you have quick way to handy links such as the Osteoporosis Guideline and other areas of the Osteoporosis Canada website. So we deemed our patient to be at low risk, but let's first do the 10-year fracture risk assessment tool. Our patient is a female, 68 years of age. Femoral neck is at -1.4 and lumbar spine is at -1.2. This puts her at low risk. Let's say she sustains a hip fracture. This brings her to high risk. Spine fracture also brings her to high risk. One non-vertebral fracture, such as a wrist fracture, brings her to moderate risk, while 2 brings her to high risk. If she was on systemic steroids, meaning the cumulative use during the preceding year at an average dose of greater than 7.5 milligrams daily, brings her to moderate risk. But if, unfortunately, she sustains a wrist fracture, brings her up to high risk. And we know that with the high-risk patient, that there's good evidence that the patient would benefit from pharmacotherapy. Let's go back to our custom form. So our patient was low risk, and we deemed her to be at high risk. Well, this brings the information from the chart of the last EGFR, and also brings you to the first line choices of pharmacotherapy. Let's remove this. Now let's say your patient was at moderate risk. The guidelines suggest that you should perform a thoracolumbar x-ray. Let's choose. You will see here that the requisition becomes populated in the chart and is pre-populated with the information to proceed to the lateral x-ray of the spine. Once the result comes in, then you proceed to your review the risk factors of your patient. If any of these are said to be yes, then there is good evidence that the patient would benefit from pharmacotherapy. And again, we are drawn to the suggested first-line therapies. Let's remove this. And let's say that our patient did not have additional risk factors, then the recommendation is to repeat in 1 to 3 years, along with encouraging healthy bone health, such as regular exercise, calcium, vitamin D, and fall prevention strategies. And now we can add to the note.
So as we talked before, you don't need to tell your computer that the patient needs to have another bone density in 1 to 3 years' time, because the computer will remember. So you don't need to, when you have a patient in front of you, go back in your chart, find the last bone density, figure out does she need it or not. You just leave the computer tell you in that reminder box. Once you've done the assessment of is she truly low risk or is she moderate risk, that conclusion will then populate your EMR and give you the answer automatically when you open your chart. So this is the Encounter Assistant.
Let's now look at our osteoporosis Encounter Assistant. F2, BMD, Encounter Assistant. Choose this form. Again, you see the information being pre-populated, and you can actually access the 10-year risk fracture tool. But this tool is integrated into the Encounter Assistant. There's a link to CAROC, and there's a link to FRAX. So according to our bone density, it deemed that our patient was at low risk. And then we go through the questions. Whether she's had previous hip fracture would bring her to high risk. Spine fracture would bring her to high risk. Non-vertebral fracture, 1 would bring her moderate risk, and 2 would bring her at high risk. If she had been on steroids, so let's say our patient is in fact a moderate risk patient, we should examine our patients to assess for physical evidence of osteoporosis, such as this. And then we assess for risk of falls, whether successful or at risk. If your patient is deemed to be at risk of falls, you can actually refer to the fall prevention program with an automated message to your staff. The practice guideline suggests that you should perform a lateral thoracolumbar x-ray. When your x-ray comes back, you then assess whether there's fracture, compression fractures or not. And the screening blood test here, you have a pre-populated laboratory requisition. So let's say our patient did have fractures. So we now have selected yes, as based on the questionnaire above. And by so, we know now that there's good evidence that the patient would benefit from pharmacotherapy. Here you can go quickly to the reference guide or to the Osteoporosis Canada website to look up the different medications. This Encounter Assistant also pulls the last EGFR from your chart. And based on the last EGFR, your choice of different pharmacotherapies. If we want to check the product monograph, and if we wanted to check the different LU codes, we want to encourage basic bone health with exercise, calcium, vitamin D, and here we have handy links like the previous custom form. Pharmacotherapy also involves vitamin D. This Encounter Assistant pulls the last vitamin D level. And we have an automated requisition that we can add to the notes and give to the patient. The vitamin D level should be done only after 3 months of taking vitamin D. This would send a delay message to your staff to call the patient as a reminder to go for the vitamin D blood test. And of course here, we want to repeat our bone density in 2 years.
So what that does then is that it populates the chart with your progress note without you having to rewrite everything. So that last click, you don't really need to do it because when you're in your chart, it will tell you your patient was moderate risk and you should repeat your bone density. The reason to do the message is that in a bone health program, you may want to be able to call back your patient to do that repeat bone density rather to wait until your patient is into your practice in your office and you open up your EMR and you see that in the reminder box that the repeat BMD has been there for the last 11 months. So that's the reason for that extra click. I have to apologize about this video. You will see here that it was done at 1 o'clock in the morning. You will see my voice trailing off, hardly awake. I need to redo it, and in fact, it has been expanded to include the Osteoporosis Foundation 13 Best Practice. So there's a lot more stuff, and as I said, if I was to show you every single tool that we've done, we'd be spending way too much time. So here is the Osteoporosis Canada custom form. And I see Mark Nelson here just from Osteoporosis Canada. Mark is one of the fracture liaison specialists. Is that your title, Mark?
regional integration.
Thank you very much. Regional Integration Lead. And Osteoporosis Canada has put a lot of time and effort into creating also EMR capabilities in order to better manage our osteoporotic patient. And this is the Osteoporosis Canada custom form, all inclusive of everything I spoke to you. So you just kind of walk yourself through. It's kind of like a resume in a condensed form of all the other tools. So you have your lab requisitions, you have your like we talked about history, physical, and investigations. You have a flow chart of your last bone density. You have your care rock that you can automatically have a peek and look at where you fall on the line. Your recommendation for your patient care. If they're moderate risk, should they or should they not be on medication, and high risk, they should be on medication. Which type of medication? So that's a concise view of all the tools I talked to you about. In order of time, we're just going to continue through this here. Mark, can you tell us how much of the custom forms, you just started rolling it out to the community?
Yeah, probably about a month and a half away to get the amendment.
Okay, so we're still not quite out in the community yet. So this is a plug for anybody that is interested. Certainly you can contact Mark, and he will help you set this up and guide you on all the ways to obtain this, to push that to your EMR. This is for the TELUS Health platform. Everything I told you about is a PSS, Practice Solution, which is a TELUS Health product. Osteoporosis Canada has done it for TELUS Health, and they're also working on it for Oscar. Am I correct, Mark?
Yes.
Yeah, perfect. So the Oscar people out there, it's coming. So for this one, there's a link to a video that explains to you how to do it and how to best manage your patient by using this tool. So let's look at post-fracture care. Now we're going to go really quickly to give time for questions. So the tools here that has been developed are the encounter assistant post-fracture. I don't have a video for that one, but what it does is that you get a report from the emergency department that the patient had a hip fracture. You open your encounter assistant, you click on the type of fracture. It sends a message to your staff for you to be able to see the patient post-fracture. That visit of post-fracture, you identify your patient of needing medication, yes or no. And then you follow through to adherence to therapy. So just by quickly going through here to the standard patient identification. So being able to identify your patient having a fragility fracture, and that's by having adding it up to your CPP like the initial video showed you, and that would generate a reminder of the bone density. Patient evaluation. You perform you ask your staff to give a bone density requisition to your patient when they're mobile enough to go and do it. And then you work through the algorithm to see whether your patient would benefit from pharmacotherapy. You want to do this in a proper timing period, and the best for level 3 for that would be, sorry, let's go back. Is an 8-week period is the best practice, level 3. So you then send your message to your staff. Same thing, you do a chest x-ray, and the chest x-ray says there's a vertebral fracture. We shouldn't ignore those people. We should actually call them back in, assess that if they have osteoporosis, and conduct a bone density review. If the bone density is low risk bone density, but with a vertebral fracture would put her at a high risk. And then we have assessment guideline, assess for secondary prevention assessment to determine the need for intervention. So for this is all the EMR tools. Basically that speaks of the 2010 Canada guideline. And then secondary causes for osteoporosis, we saw that we have an automated populated requisition based on whether the patient has a vertebral fracture, yes or no. The difference between those two requisitions is the protein electrophoresis for those that have sustained a vertebral fracture. So we have that one. And then we have fall prevention. Well, we went through the algorithm from the Champlain-Lynn that describe an easy way of doing the fall prevention. The nice thing about that toolbar is that if you've done your screening, the toolbar disappears. It's not in front of you, so automatically you know you've done it in the last year. If the toolbar reappears, you are 1 month away from needing to do the screening test. And you'll see that there was a date at the very end part of the toolbar, there was a date performed on, and you'll see the date. Because you don't want to miss that opportunity if you're at 11 months and you know your patient's not going to be in for another 6-9 months to perform that fall risk assessment. And this one here, so the multifactorial risk assessment. I didn't do justice to the video to show the encounter assistant of the multifactorial risk assessment, but basically it replicates the paper base and you just go through and click the answer and you populate the boxes. So medication initiation standard. So 90%, level 3 would be 90% of patients who are eligible for treatment are treated. I would strive for 100% of my patients who are eligible are offered treatment, and that by working through the custom form and encounter assistant helps you determine whether your patient should be on medication or not. I like doing the bone mineral density encounter assistant with my patient in front of me. I like showing them the X-ray or the sheet of the old lady that is curving down with the skeleton that is going down. I think that's very powerful. They understand when they see something visual rather than in words. And we know that if we put things too complex to our patient, they become confused about what did she say, yes or no. So keeping it simple for them to make them participate in their care is very important. And medication review by sending a delay message in 3 months and a year. Automatically that was populating to the staff. It's not activities that I need to do. So a lot of the activities in the EMR tools that we've done are actually staff and care team activities. Communication strategy, well, using the dashboard, long-term management, and actually doing all the tool brings that. And the database, as I say, we don't have yet in terms of a provincial or national database. Maybe different for Osteoporosis Canada, but it's not integrated into the EMR. The nice thing is being able to draw all of that information. It's nice to click, click, click and put information in the EMR, but it's fun to know what you can do when you actually entered in a consistent way your information. So for your post-fracture care, you can actually ask your EMR, how many of my patients actually had wrist fracture, hip fracture, pelvis fracture? How many activities of those post-fracture has been done on those? Let's say I had 7 patients in the last year who sustained a fracture. How many had a bone density done? Oh, wow, everybody had a bone density done. Great. How many had a bone density done that I actually took the time to review if they're low risk, they're actually high risk? Only 3. I need to be better on that. How many had a lateral view of the spine to assess for vertebral fracture? How many had their investigation? How many had lifestyle counseling? So you can actually pull that, and that's what I meant by the dashboard. You can actually pull that information, and you can actually then go to the patient that's missing the most activities and say, oh, geez, this one I need to do this, this, and this. And you can actually look at it by patient. So patient number 6 did not get appropriate care. I can call that patient. I can do those activities in order to prevent another fracture. So this brings me right on the 10-minute mark for questions. So I understand that, oh, thank you. I understand that there's people online that may want to ask questions. So we start with them, but I'll let Al here do the technology part for those questions.